online research bootcamp. I am Rainier Kovar, and I will serve as your moderator this morning. To give you a brief overview of this project, this is a webinar series designed for ophthalmologists, ophthalmology fellows, and residents in training that will focus on the must-knows of research. This is divided into three modules, where evidence-based medicine, research methods, and research in ophthalmology will be discussed in detail. We will be having 8 very exciting research field sessions, which will be broadcasted in 3 platforms, via Zoom, Facebook Live, and YouTube. To formally begin this event, I would like to call on the President of the Philippine Academy of Ophthalmology, Dr. Margarita Latluna, for the opening remarks.
Thank you very much, Rainier. Good morning. Welcome, dear participants, to the Philippine Academy of Ophthalmology Research Bootcamp, organized by the Committee on Research headed by Dr. Rainier Kovar. We welcome and thank the distinguished panel of lecturers who will be serving as your mentors during the series of learning activities. Perhaps it was serendipitous that last night I came across a movie on YouTube that was based on the story of the whistleblower in South Korea who courageously revealed to the world that the scientist who was already being honored as a hero did not actually clone any stem cell. This whistleblower was part of the team of this scientist, but when he realized that nobody had actually witnessed the cloning of the stem cell, he could not bear to be a participant in the fraud. He was up against so many of the higher-ups in their scientific world, and even multitudes of ordinary citizens were criticizing him. The tide turned when a group of right-minded people expressed that suppressing the truth, no matter how painful, is actually more harmful. And the rest, as they say, is history. The scientist was stripped of the honors given to him. I hope that this research bootcamp will prepare you not only technically to be astute researchers, but more importantly, to be researchers with integrity. You can be assured that the Philippine Academy of Ophthalmology will strive to support all the efforts in ensuring the performance of ethical research that will be for the benefit of our countrymen. Congratulations once again to the organizers, the implementers, and the technical team of this research bootcamp. Welcome and stay safe.
Thank you very much, Marge. So for the next part of our program, I would like to introduce to you our inspirational speaker. He received his medical degree from the University of the Philippines College of Medicine in 2001. He trained in internal medicine at the Medical College of Wisconsin in Milwaukee and finished his fellowship in infectious diseases and tropical medicine at the Case Western Reserve University in Cleveland. He returned in 2008 as a Balik scientist of the Department of Science and Technology. He is currently the director of the Institute of Molecular Biology and Biotechnology at the National Institutes of Health and is an associate professor of medicine at the Philippine General Hospital. He has been selected as an astounding young scientist by the National Academy of Science and Technology and has been awarded one of the 10 outstanding young men in the Philippines for medicine and social activism in HIV. He has also been selected as one of the 10 outstanding young persons of the world and a young physician leader of the Inter-Academy Medical Panel of the World Academy of Sciences. Unfortunately, he won't be able to join us live today due to an urgent DOH meeting, but he sent us a recorded message instead. So without further ado, let us hear from a renowned scientist, Dr. Edsel Salvania.
Good morning, everyone. Congratulations to the Philippine Academy of Ophthalmology for pushing through with this very important research workshop, even in the midst of the pandemic. It has been a challenging few months for all of us, but we need to continue the work that makes life worth living. I think everyone agrees that research is important. It generates new knowledge, it instills a high level of discipline, and it changes the way a person sees the world. Researchers are the most skeptical and also the most optimistic people in the world. Skeptical because we tend to question even established practices because we know that knowledge is evolving. Optimistic because despite knowing how uncertain everything is, we trudge on in search of new knowledge. I'm not going to tell you how to do research in this short talk. That's what this workshop is for. I'm also not going to tell you why you should do research. You already know how important it is, especially during this pandemic. Otherwise, you wouldn't be in this workshop. Instead, let me tell you why you shouldn't do research. I think it is only fair that you know what to expect. If your heart and soul isn't into it, you might just end up wasting your time. Number one, don't do research if you want quick answers. Usually, the answers you get from research aren't what you expect. And these answers end up asking more questions. Number two, don't do research if you're easily depressed. Mental fortitude is a key skill when things don't work out. Most of the time, they won't. Don't do research. Number three, don't do research if you don't know how to fail. 99% of your experiments will fail, and you won't know why they failed most of the time. It just makes it so much sweeter when it actually works. Number four, don't do research if you're looking for lots of money. Rarely, some researchers hit it big with a brilliant invention. Most of the time, though, you will not be properly compensated for your efforts. Far from it. You waste a lot of time. Other than having the satisfaction of having contributed something to the quest for human knowledge. Number five, don't do research if you don't have time. None of us have enough time, but you have to be willing to cut out other things to make time for research. It isn't something that can be crammed. The fastest way to fail as a researcher is to treat it as something that you have to do on top of everything else you are doing. It has to be one of your priorities if you really want to make something of it. Now, before you run away from this workshop and your moderator shut me down, let me tell you why you need to know this. Not everyone is built to be a researcher. And that's okay. Not everyone should do research. And that's okay as well. However, the skills that you learn from doing research are useful skills for life. Even if you never publish a peer-reviewed manuscript, although hope you do though, or invent the cure to cancer, having gone through research training teaches people discipline, patience, mental fortitude, and critical thinking. It also teaches people a healthy respect for precious knowledge that we so often take for granted. Having said that, I do hope that at least some of you do become researchers. If despite everything I have said and everything you will experience on this road, you persevere and come back for more, then the Philippines and the world will be a better place for it. We need more seekers of knowledge. To become one, there will be sleepless nights, uncertainty, and lots of figuratively banging your head against the wall. It will either make you bitter or better. Consider yourselves warned. If you choose to stay, then I look forward to welcoming you to the club. Best of luck on this journey of science. Thank you very much.
Thank you, Edsel, for that inspiring message. You gave us a good perspective and definitely made us not want to get into research. I think we just lost half our viewers. But seriously, Edsel is a well-respected researcher and clinician. We applaud him for his efforts in helping with the DOH and IATF. I'm pretty sure they need all the help they can get. At this point, we would like to remind everyone that questions will be entertained at the end of the lecture. So for those of you who have questions, you may put questions at the chat box. Now let me start by introducing our resource speaker for today and for the succeeding 6 sessions. Our speaker is an assistant professor of epidemiology at the Department of Epidemiology and Biostatistics, College of Public Health at UP Manila. He is currently a PhD student in epidemiology at the Department of Epidemiology, School of Public Health, Brown University in Providence, Rhode Island, as a US NIH Fogarty Doctoral Fellow. He obtained his Doctor of Medicine degree in 2009 from the College of Medicine of UP Manila under the Integrated Liberal Arts and Medicine program. In 2014, he completed his Master of Public Health degree from the College of Public Health of UP Manila. Prior to doctorate studies at Brown, Dr. Bermudez has undertaken research projects funded by the Department of Health, World Health Organization, United Nations Children's Fund, Asian Development Bank, Health Futures Foundation Incorporated, Philippine Business for Social Progress Incorporated, and Johnson & Johnson Philippines, among others. Let us now welcome Dr. Amiel Bermudez to give his lecture on evidence-based medicine and basic steps in critical appraisal of medical literature. Good evening, Amiel. Hope you're doing well in Rhode Island.
Hi, Dr. Kovar. Thank you for that introduction. Good evening, everybody. I'm very excited to be joining you in your research bootcamp. And I hope you learn something at the end of this session. Okay, can I start already? I'll start with the first lecture. Okay, so for this morning, we'll have 2 lectures. I'll have a first short lecture on an introduction to evidence-based medicine, followed by the evidence-based medicine process, which is actually quite longer. Okay, so at the end of the session, you should be able to define what evidence-based medicine is, discuss the 3 components of EBM, discuss the 3 principles of EBM. So we'll be devoting some time discussing these principles, and then enumerate the specific knowledge and skills that's necessary for optimal EBM. And then, of course, let's try to go through some of the challenges that you would encounter, or maybe you're now encountering in your practice of evidence-based medicine. Okay, so let's start with basic definitions first. Let's start with the definition of evidence-based practice. I like this definition from Sackett in 1996. Sackett defined evidence-based practice as a conscientious, so it's something that you deliberately think of, that you deliberately practice. It's conscientious, explicit, judicious use of current best evidence in making decisions about the care of an individual patient. So in here, you see what the motivation of evidence-based medicine is. Okay, the motivation is deciding on what's best for your patient. And in order for you to do that, you have to make use of current best evidence. I need to emphasize that. It's not only the best evidence, it's something that's current. Okay, so your evidence-based practice actually involves an integration of 3 components. The first is clinical expertise. The second is patient values and preferences. And then the third is best research evidence. So it's actually a misconception and a grave error when you think of EBM as just focusing on research evidence. Actually, it's not. Okay, research evidence, or the integration of research evidence, is just a part of it. EBP or EBM relies on your expertise as ophthalmologists, as clinicians. And then, of course, you have to consider what the patient, what the patient will bring to the table. Because ultimately, when you integrate these 3 components, then you facilitate a better decision-making process for patient care. Now, EBP is not something that's, that comes out of the blue. It's actually triggered by patient encounters. And during these patient encounters, You may generate questions about the effects of therapy, which therapy is best, which therapy is better for this particular patient. Or you may generate questions about the utility of your diagnostic test. When we talk about the accuracy of your diagnostic test, especially in ophthalmology, right? And then maybe you generate questions about prognosis or even the etiology or cause of disorders. Now, EBM is a more specific aspect of evidence-based medicine or evidence-based practice. So in other fields of medicine or other fields of healthcare, you would encounter things like evidence-based nursing or evidence-based dentistry. So evidence-based medicine is but a specific aspect of evidence-based practice. Um, by definition, evidence-based medicine again involves conscientiously. So this word comes in the definition of both EBM and EBP. So it's something that's deliberate, it's something that you think about. So it involves conscientiously working with your patients to help them resolve or cope with their problems related to their physical, mental, and social health. So as EBM practitioners, you strive for a clear, and I need to emphasize these keywords, clear, comprehensive understanding of the evidence underlying your clinical care and work with each patient to ensure that chosen courses of action are in the patient's best interest. Again, in this definition, you see the three components of evidence-based medicine. So there's the use of evidence. It's not just mere use of evidence, it's a clear, comprehensive understanding of evidence. And then, of course, working with patient, you figure into this process as practitioners because ultimately you want to come up with a course of action that promotes the patient's best interests. I'm Evidence-based medicine or evidence-based practice provide healthcare providers with best evidence-based data or information to resolve problems in the clinical setting and to achieve excellence in healthcare delivery. So these are the goals of evidence-based medicine or evidence-based practice. Another important goal of EBM is to reduce variations in healthcare. This is something that we don't really like in clinical medicine. Okay, that's why we come up with clinical practice guidelines, right? Of course, there would be some variations in the way we approach our patient, but we want that, these variations do not deviate much into the quality, right, that we provide to our patients. That's why your clinical practice guidelines or consensus recommendations are actually developed to reduce these variations in healthcare. And in the development of your CPGs, a lot of the principles of evidence-based medicine actually come in. EBM also promote effective health interventions because if you know what's best for your patient, then the more likely it is that this best intervention is applied. Okay, EBM assists with efficient and effective decision making. Now, I mentioned this a while ago. This figure will show you the three components of evidence-based medicine. So you have clinical expertise. This is where you come in. So clinical expertise refers to your accumulated experience, your education, and your clinical skills. Okay. So the physician's clinical expertise is an integral component in the EBM process. Of course, there's best research evidence. And I want to emphasize that best research evidence is usually found in clinically relevant research that has been conducted using sound methodology. That's why in evidence-based medicine, we see a lot of focus on validity issues. Okay, we look into if the study is free from bias, for example. So this is where the best research evidence component comes in. And then, of course, you need to go back to your patient because your patient will bring to the encounter, his or her own personal preferences, his or her unique concerns, expectations, and values. So, if there is one very important slide for this lecture, it's this one. Okay, please take note that there are three components of EBM. It's not just research evidence, even if it's evidence-based medicine, okay? research evidence is just one part of it. Critical appraisal is just one part of it. Okay, actually, the majority of the process and even the majority of the decisions would come from your expertise, and then the patient's values and preferences. Okay, so there are three fundamental principles of EBM. We'll go through this in detail in the succeeding slides. The first principle is that optimal clinical decision-making requires awareness of the best available evidence. Okay, so the best clinical decision for a particular patient requires awareness of best available evidence, and this usually comes from systematic summaries of your evidence. Okay, that's the first fundamental principle. The second fundamental principle is that your evidence-based medicine provides guidance to decide whether evidence is more or less trustworthy. So EBM is not prescriptive. Okay, EBM is a framework, it's a way of thinking. It provides guidance on deciding whether the evidence that you obtained from your literature search is more or less trustworthy. Okay, the third principle is that, and I like this, evidence alone is never sufficient to make a clinical decision. You would know this, it's actually very intuitive. In your clinical practice, as a matter of fact, right, you don't really rely on a lot of evidence, right? You rely a lot on your clinical expertise, which has been accumulated through several years of training, right? But it's the same principle actually. So no one component of EBM should dominate the clinical decision-making process. So in this slide, we're emphasizing that evidence alone, okay, is never sufficient to make a clinical decision. It's an integration of the evidence, the patient's unique predicament, values, and preferences, as well as your clinical expertise. Okay, let's start with the first principle. The first principle talks about optimal clinical decision-making requiring awareness of best available evidence. Why is this so? Okay. This is so because rational clinical decisions would require systematic summaries of the best available evidence. Without such summaries or without such evidence, clinicians will be unduly influenced by their own preconceptions, or maybe by evidence that is unrepresentative or evidence that has lower quality. So we need evidence as a sort of benchmark to determine if what we're doing is actually the best. Okay? Without such evidence, then of course you'll just, there's really no way for you to find out if what you're doing is correct or not. Right? So we need that type of benchmarking. Again, the use of evidence will also prevent us from relying on research findings that are unrepresentative of what's written on the field or even research that has low quality. For principle number 2, I did mention this a while ago, evidence-based medicine provides guidance in determining whether evidence is trustworthy or not. So you can think of EBM as a guide to determining whether you should have confidence in a particular research finding. So your EBM provides guidance to distinguish trustworthy from uncertain evidence and even the range of confidence between them. So for principle number 2, you're essentially asking the question, what is the best evidence? And there are several ways to answer this. Okay, traditionally, this question is answered by what we call hierarchies of evidence. I'll show an example of what a hierarchy of evidence is, although I need to make a disclaimer that hierarchies of evidence is a contentious issue in the field of epidemiology or clinical epidemiology lately. But you'd still see a lot of EBM practitioners using hierarchies of evidence to answer this question. What is the best evidence? Okay, in recent years also, because of the limitations of hierarchies of evidence, we now use what we call confidence assessment criteria. And we borrow from the methods of CPG development. So I'll show you an example of a confidence assessment criteria later on. Okay, so what I need you to take home from principle number 2 is that your EBM allows you to answer this question: what is the best evidence? And we answer this question by using hierarchies of evidence or your confidence assessment criteria. Okay, so this is an example of what we call a hierarchy of evidence. We call this the traditional evidence pyramid. Okay, if you've taken clinical epidemiology in medical school or maybe in graduate school, you may have seen this presented. Uh, you have here a pyramid, right? And as you ascend through the pyramid, the validity or the accuracy of your findings increase. So the traditional evidence pyramid postulates that findings from your systematic reviews and meta-analysis provide the best evidence, okay? Best evidence, let's say, for the effectiveness of an intervention, okay? After your systematic reviews and analysis, systematic reviews and meta-analysis, the next best option would be your randomized controlled trials. If you don't have your randomized controlled trials, the next best evidence will come from your cohort studies. If there are no cohort studies, next best evidence will come from your case control studies. And then if there are no case control studies, then the least best evidence or the least, best evidence would come from your case reports and case series. So this is what I've been traditionally taught in epidemiology, that there's such a thing as a traditional evidence pyramid. As you ascend through the pyramid, then the better the evidence is. Okay, that's why they always say that a randomized controlled trial is the gold standard when you want to assess the effectiveness of interventions. And they say that a systematic review and meta-analysis, which is actually a collection of your randomized controlled trials, would qualify as the platinum standard, right? So I've been taught that. However, in epidemiology now, there are some epidemiologists who don't believe in this anymore. So I just want to open up that discussion that you won't really see a lot, especially in recent literature in evidence-based medicine. You would, increasingly see what we call a revision of the pyramid. Okay, so this is a revision of the traditional evidence pyramid. It still kind of looks like a pyramid or a triangle, but you see here that the lines separating the study designs become wavy. What does that mean? It just means that there are some poorly conducted, for example, for randomized controlled trials and cohort studies. There are some poorly conducted randomized controlled trials that are actually worse than a well-conducted cohort study. Okay, and as an epidemiologist, I'm more inclined to think of it that way, right? Not RCTs, not all RCTs are created equal. You would be surprised that there are a lot of RCTs which are really not conducted very well, okay? So it's not because it's an RCT, does it mean that it will provide you the best evidence. For certain instances, a well-conducted cohort study will actually give you a better evidence than a poorly conducted randomized controlled trial. It's a similar the interface between your case control study and your cohort study. So it's not a matter of what the study design is. It's a question of whether you carried out the study correctly or not. So these authors, Hassan Murad, actually proposed this, that it's not actually a straight line that separates the study designs from each other. It's a wavy line. And then you would notice here that the systematic reviews at the top are chopped off. Why? Because we now use systematic reviews as a lens through which your evidence is viewed. Because your systematic review is actually a way for you to synthesize findings from these studies. And when you carry out a systematic review, there's a part of the systematic review process that looks into the quality of these studies. So your systematic reviews and meta-analysis is actually a way for you to view, okay, or to assess the quality of these studies. So I'm more inclined to view the evidence pyramid this way, okay? So this is an example of hierarchies of evidence. Essentially, this answered the question, what is the best evidence? The take-home message here, it's not a matter of what the design is. It's a question of whether the study was carried out correctly or not. Okay. As an example, there are randomized controlled trials that are poorly done and would result in findings that are less accurate than those obtained from a well-conducted cohort study. Now, in addition to hierarchies of evidence, we have what we call your confidence assessment criteria. So these are actually more sophisticated frameworks that have emerged in recent years for judging confidence in the estimates of treatment effect. So you'll be hearing this term treatment effect. What does that mean? Maybe you're more familiar with the relative risk. So the relative risk, or RR, is actually an estimate of treatment effect. It quantifies how beneficial a particular treatment is for a given intervention compared to a control intervention. So when we talk about estimates of treatment effect, we talk about the relative risk, we talk about the risk difference. In some instances, we talk about the odds ratios. So those are estimates of treatment effect, okay? So we actually employ very sophisticated frameworks to judge confidence in these quantitative estimates of treatment effects. And a very popular confidence assessment criteria is the GRADE framework. It's actually an acronym. You would see this in your clinical practice guidelines. The GRADE stands for Grading of Recommendations, Assessment, Development, and Evaluation. So it's originally intended to provide an approach to the development of your CPGs, but we're using it increasingly in evidence-based medicine, even in the critical appraisal of literature. So when you use the GRADE approach, you're actually rating confidence in the estimates of effects of healthcare interventions. We also call this the quality of evidence. And you rate it as high, moderate, low, or very low. Okay, so that's, there's actually a whole workshop on the application of the GRADE framework. So we won't really focus on that in this workshop or in this session. But it suffices for you to know that when we apply GRADE, we actually force ourselves, right, to rate confidence in estimates of effect. Okay, and these ratings would range from high to very low. Okay, so these ratings we call quality of evidence. I'll just give you an overview of the GRADE framework. So this is a very simplified approach in the application of GRADE. Okay, so let's say if you're given a particular RCT, or you're given a particular article, for example, then you will need to classify that article if it's a randomized trial or an observational study. And then once you have classified that, you need to look into such issues as risk of bias, inconsistency, indirectness, imprecision, and publication bias. Okay, sorry, it's not just one article. It's usually a collection of articles, right? Focusing or addressing the same question or even estimating the same relative risk. So you start with that and then consider such issues as risk of bias, inconsistency, indirectness, imprecision, and publication bias. So it's all very complicated. There's actually a software, okay, that will help you automatically rate confidence in estimates by encoding some inputs for all of this. Okay, it's just to familiarize you that there's such a framework called GRADE that we use to rate the quality of evidence from systematic reviews and meta-analysis. Okay, the third principle now is that evidence is never enough to drive clinical decision-making. And this is very true because you have to factor in the values and preferences of your patients. Okay, and by definition, values and preferences would refer to goals, expectations, predispositions, beliefs that individuals have for certain decisions and their potential outcomes, right? There will be instances, or there may have been instances in which your clinical decision and the best evidence are congruent, but the patient won't agree to it, okay? And in such instance, even if your decision and the evidence conflict with that of your patient, you're sometimes forced to just comply with the patient's wishes, right? So I think that drives the point that evidence is never enough to drive clinical decision making. So when you do this in clinical decision making, there's actually an explicit enumeration and balancing of benefits and risks. And when you do this, okay, actually the balancing of benefits and risks involve value judgment. And this is something that you do, for example, or that you practice with your patients. Okay, so those are the three principles. So far we've covered basic definitions of what evidence-based medicine is, evidence-based practice. We've covered the components of evidence-based medicine, the principles of evidence-based medicine. So we're now on that part of the lecture that focuses on knowledge and skills that's necessary for optimal evidence-based medicine. Okay, so the first would be your diagnostic expertise, of course, because there will be questions on diagnosis. So you need to have this diagnostic expertise, an in-depth background knowledge. This is very important. Effective literature searching skills. I hope medicine and residency training or even fellowship training is supposed to equip you with the first two, your diagnostic expertise and in-depth background knowledge. Effective literature searching skills, something that we can address in this workshop. Effective critical appraisal skills is also something that we can address, hopefully, at the end of 4 sessions, including this session. Okay, ability to define and understand benefits and risks of alternatives. So, this is something that you develop as you build through your clinical practice and as you see a lot of patients, right, in your clinics. Uh, this is more of an effective skill in a way. Okay, in-depth physiological understanding that allows you to apply evidence to the individual. So, uh, hopefully, medical school and residency is supposed to equip you with this. Sensitivity and communication skills required for full understanding of patient context. Because later on, when we talk about the steps of EBM, the first step is always asking the patient. So if you don't have good communication skills, then you won't really know what's bothering the patient. Okay. And then ability to elicit and understand patient values and preferences and work with patients in shared decision making. So something that you can develop in medical school, in residency, fellowship training, and even as you build your practice. Okay, so evidence-based medicine is not easy, okay, but it's actually a good expectation of clinicians, right? I actually agree with Dr. Salvano when he mentioned that not everybody can be researchers, but I believe that all physicians should be good consumers of research, right? So even if evidence-based medicine is difficult, then we must prevail through these challenges. So these are just some of the challenges for evidence-based medicine. And I hope you'll reflect through this and then in your own introspection, decide how to prevail through these challenges. So the first, we can all agree that there are time limitations, right? Perceptions may arise from having inadequate access to various evidence-based resources, especially if you're too busy in the clinic and then you encounter several patients, you may not have the time to practice EBM at all, right? And this is aggravated by the fact that you may have limited access to evidence-based resources. However, please be mindful that in this present day and age, especially since we're shifting a lot of our practice online, okay, there's now an array of sophisticated evidence-based information that's available to you. So we have what we call pre-processed information, right? So you can actually access pre-processed information. We'll talk about this in more detail in the next lecture. But please take note, an example of pre-processed information is Medscape. Okay, so if you're using Medscape, a lot of the material presented there are pre-processed information. The only downside of that is you can't, when you access pre-processed information, sometimes you're not given the opportunity to hone other skills required for evidence-based practice. An example of what they call this, a particular skill that's being left out would be your effective literature searching skill. Okay, so just be aware of that downside. Medscape, for example, is very helpful for a lot of physicians. It gives them pre-processed information that's of high quality, for example. But if you rely on that 100%, then you're missing out on other skills that's necessary for you to become an effective and efficient EBM practitioner. Okay. Another challenge for evidence-based medicine is ensuring that your strategies, your management strategies are consistent with patients' values and preferences, right? So I really don't have an answer to the question of how to address this. I can just help you clarify what the challenge is. It says here that in a time-constrained environment, how can we ensure that patients' involvement in decision-making has the form and extent that they desire, and that the outcome reflects their needs and desires? So it's all a matter of communication. It's all a matter of being sensitive to what your patient's needs are. Okay, so these are my references for this lecture. I'm ending 2 minutes ahead of time. At this point, do we have questions from the audience before we pause for a short break, and then we'll commence with the second lecture? Okay, so there are no questions at this point. It's now 9:43 in the morning. Can we have a 2-minute break? Let's resume at 9:45 for the meat of the matter, okay, which is the evidence-based medicine process.
Hello, everyone. So that has been an introduction to evidence-based medicine by Amiel. We actually started this concept of having this research bootcamp so that we can equip all you residents who we know are busy with your patients in your hospitals, to equip you with the knowledge that you may need when you're reading the journals, when you're asked by your consultants to report on certain things. So we have to realize that journals don't have the same quality everywhere. So we have to know how to be able to distinguish which journals should be read first, which journals will weigh in evidence compared to other journals. So we should be able to discern on which ones should be good enough for us to echo or to report on. And at the same time, which ones will have good knowledge for us to imbibe or to learn from. So that is one of the key things that we must know. And actually, later on, when you do your research studies, when you do your required research papers, you will be able to make a sound experiment, a sound study, and be able to more or less get good evidence on whatever you're experimenting on or reporting on, or if it's a retrospective study. So you should be able to make a good design out of whatever materials you have at this point. So let's wait for Amiel to finish or for him to have a break. And when you're ready, Amiel, are you okay?
Oh, yes, sir. I'm
Okay.
back.
Okay, welcome back.
Okay, so we'll now move to the second lecture for this module. Let me just share my screen. Okay, and this is the meat of the matter. Okay, so the 30-minute introduction is just to introduce you to what evidence-based medicine is. Okay, so the majority of the hours or the minutes we have So far, we'll be focusing on the evidence-based medicine process before we even delve into critical appraisal of literature. Okay, so this is our set of learning objectives. At the end of the session, you should be able to describe ways in which clinicians use the literature, enumerate the steps in the evidence-based medicine process, specify a clinical question that is amenable to an effective and efficient literature search. Uh, Ordinarily, if this were given as a face-to-face workshop, we would have, we could devote some time specifying on a clinical question, but I'm just banking on you doing it on your own and you have the time. Conduct a focused search of literature guided by your clinical question, and then discussing considerations when you're assessing the validity of studies and in applying your study results to your patients. Okay, so I usually start the discussion by asking residents or participants how they use the medical literature and why they use the medical literature. Essentially, reasons and strategies in the use of medical literature can be divided into three. Okay, a lot of clinicians use medical literature to stay alert to important new evidence. Okay, they use the medical literature for problem solving and in asking background and foreground questions. So these are the most common reasons, okay, why clinicians use the medical literature, and we'll go through this one at a time. So the first, clinicians use medical literature to stay alert to important new evidence, right? So they use medical literature to answer this question. What important new evidence should I know to optimally treat patients? Traditionally, to answer this question, you have to attend rounds, conferences, or by subscribing to target medical journals in which articles that are relevant to your practice appear, right? However, a drawback to this method, for example, let's say subscription to a target medical journal, is that a lot of your screened articles may be irrelevant or even fail to meet critical appraisal criteria. Okay, maybe you have encountered websites that will actually show you screened articles already. So you just have to be like while that is very convenient insofar as answering this question is concerned, you have to be aware that maybe a lot of those screened articles are not relevant to your question, or if they are, these articles may fail to meet important appraisal criteria. So again, it emphasizes on you actually doing the searching and the appraisal yourself. Okay, another drawback to subscribing to a target medical journal, and I'm assuming that at some time in your life as medical students, you have subscribed to a target medical journal. When I was a medical student, I subscribed to the New England Journal of Medicine. Okay, but it's I found myself just deleting the email afterwards, never finding the time to go through the article because of these reasons. Okay, the second one being that the volume of research is actually markedly increasing. And even if these articles are what they call this are actually relevant, then it kind of becomes unmanageable given the volume, okay, of articles that you would see. Okay. So, an efficient strategy to ensure that clinicians are aware of recent developments relevant to your practice is what we call your email alerting systems. Okay, so if you still want to what you call this, if you want to stay alert to important new evidence, I highly suggest that you subscribe to what we call email alerting systems. Okay, so these are examples. I'll give a copy of my lecture slides so you can have access to this. Okay, so these are examples of your email alerting systems. So this is maintained by McMaster University. It will actually, what we call this, notify you if a new evidence about your topic of interest emerges. Okay, so there's evidence updates for internal medicine or for general medicine. There's New England Journal of Medicine Journal Watch, right? So these are just two of the email alert systems that I recommend. I don't think I have found what they call this an email alerting system for ophthalmology. Kind of difficult actually to look for EBM resources specific for ophthalmology. But I think evidence updates and the New England Journal of Medicine Journal Watch would be a good start. Okay. Now, the second reason why clinicians use the medical literature is for problem solving. So clinicians would define specific clinical questions that would arise from issues encountered in the management of an individual patient, and then consult the medical literature to resolve these questions. Okay, so let's say when you interact with your patient, when you manage a patient, there may be specific questions that would arise from that interaction. And these are questions for which there is no ready answer. And so you're left with consulting the medical literature to resolve these questions. So, as a matter of fact, this is the major reason why we're using the medical literature. It's for clinical problem solving. Okay, so let's say in general medicine, we may ask questions such as in patients with new onset type 2 diabetes mellitus, which clinical features or test results would predict the development of diabetic complications, right? Or so this is a question of diagnosis. The second one, on the other hand, is a question of treatment. The starting with metformin yield improved diabetes control and reduce long-term complications better than other initial treatment. So this is an example of a question on diagnosis. This is a question on treatment, okay? And then the last reason, at least for this particular slide, why clinicians use the medical literature is when they're asking background and foreground question. And I'd want to emphasize the difference between the two. Okay, so your background questions are questions about the underlying pathophysiology or epidemiology of a disorder, and these are usually addressed by your traditional medical textbooks. So the earlier you are in your practice as a physician, as an ophthalmologist, you may be asking a lot of background questions. However, as you develop your expertise, as you become more experienced, you will eventually be asking a lot of foreground questions, and these are questions that experienced clinicians usually ask. In evidence-based medicine, we ask foreground questions. Please take note of that. Okay, knowledge of pathophysiology, epidemiology, etc., the basic sciences of a particular discipline are important for you to understand answers to foreground questions. But in evidence-based medicine, it's usually the foreground questions that we ask. What are foreground questions? So these are questions that concern diagnosis, questions that concern treatment, prognosis, harm. Okay? So as you go through, as you develop your expertise, right, from novice to expert, the higher, so there's a change now. Okay, so as you go from being as you travel from being a novice to being an expert, the amount of foreground question that you ask increases a lot relative to the number of background questions that you ask. Okay, so again, emphasizing that, in order for you to be an effective EBM practitioner, you need to have that clinical experience in a way. Okay, so what do I want to point out in this slide? In EBM, we ask foreground questions. We don't ask the pathophysiology or the epidemiology of a disorder. These questions are important to put some context to the issue, right? But still, at the end of the day, the majority of the questions or all of the questions that you ask in evidence-based medicine are foreground questions. Okay. In most situations in evidence-based medicine, you need to understand the background thoroughly. So these are the background questions before it makes sense for you to address foreground issues. So as clinicians, experienced clinicians, you may occasionally require background information. I'm not totally discrediting background questions, right? You may occasionally need this to put some context into questions on, let's say, diagnosis, therapy, prognosis, or etiology. Okay, let me go through that again. In the majority of situations in EBM, you need to understand background questions or background issues more thoroughly before you can understand foreground issues. But there will also be instances in which you need background information when you encounter a new condition or a syndrome, a new diagnostic test, or a new treatment modality. In epidemiology, we call this the background information, that would usually fall on descriptive epidemiology. Okay. Now, so we're now moving on to the meat of the matter, the step in the EBP process or the EBM medicine process, the steps in the evidence-based medicine process. Okay. The first is you assess the patient. The next step is you ask the question. The third is you acquire the evidence. The fourth is you appraise the evidence. And then the last is you apply or you talk to your patients. So they all start with A. So you assess, you ask, you acquire, you appraise, then you apply. Okay? So assessing the patient, you always start with the patient. A clinical problem or a question will arise from the care of your patient. When we talk about asking the question, we talk about constructing a well-built clinical question that is derived from your patient, that is derived from the case or the physician-patient encounter. Okay? So very important, start with an assessment of your patient because that patient-physician encounter will usually give rise to a particular issue. And that particular issue you convert into a well-built clinical question. So it's always that patient-physician encounter or interaction that gives rise to a clinical question. So this is not, evidence-based medicine is not developing a research proposal. That's a different story altogether. There are similarities actually, okay? But in here, the motivation for building a clinical question is that patient-physician interaction. It's that issue that you obtain from talking or assessing your patient. Okay, so assess your patient, you ask the question. After you have built your clinical question, you now need to acquire your evidence. And this means that you need to select the appropriate resources and conduct an efficient literature search. After you have acquired the evidence, you need to appraise the evidence. Okay, so you appraise the evidence. There are two issues here. You appraise for validity and applicability. So it's always, that's a recurring theme. When you do critical appraisal, you talk about the validity of your findings and then whether the findings are useful in clinical practice. So validity refers to how close the study findings are to the truth. And validity is more of a function of good study design. Okay, so we'll be teaching you in the next sessions how to assess the validity of study findings. So it's always that they go hand in hand, validity and applicability. It's possible that the study has, it's possible that the study is highly valid. It's a well-constructed study. But even if it's highly valid, there are instances in which such findings cannot be applied to a particular patient because of logistical issues. Or, for a reason as simple as the medicine or the drug being not available in the Philippines, right? So these two should go hand in hand, questions on validity and questions on applicability. It can also happen the other way around. A particular intervention may be applicable to a patient. It's cheap, it's readily available. It can be administered quite easily. But when you check on its validity from several RCTs, for example, you would see that the study was not conducted correctly. So it's a balance between the two, validity and applicability. So after you appraise the evidence, then you apply it to your patient. And this would include talking to your patient. You return to your patient, you integrate that evidence with your expertise and the patient's preference, and then ultimately apply it to practice. Okay, so let's go through these steps one at a time. We'll focus on assessing the patient and asking the question. Okay, so the primary question that's supposed to guide you in this step is this. What is the problem, the issue, the question that arises from the care of the patient? Okay. Again, I've been repetitive in this. Okay, the motivation for a clinical question is a patient issue. Okay, I repeat, the motivation for a clinical question is a patient issue that you obtain from your interactions with your patient. So, what is the problem, the issue, the question that arises from the care of the patient? Now, once you have identified the problem, issue, or question, you now construct a question. Okay, you now construct a clinical question that is based on the identified problem or concern. Um, in here, you need to phrase your question in such a way as to facilitate answering or facilitate finding an answer. So, the question that comes out of point number one may be in such a form that's not amenable to effective searching. Okay? So you need to convert that particular question into something that can facilitate finding an answer. Okay? And this would include being aware of the anatomy of a good clinical question for intervention. So there's the PICO, your population, your intervention, your comparison, and your outcome. Okay? I'll give an example. Maybe something that arises from the interaction of your patient is the question, will this drug work? Right? So it's a very general issue. It's a very general concern, but that question in itself will not help you find an answer. Okay? You have to convert that question into something that will make it easier for you to find an answer. So will this drug work? Okay, that's a very general issue. So you will need to reconstruct that. Okay, you will need to rephrase that in such a way as to facilitate finding an answer. And how exactly do you rephrase that? Okay, you specify the anatomy or the components of a good clinical question. That would mean specifying the population, the intervention, the comparison, and the outcome. Okay, so clarifying the clinical questions. Your clinical questions often come to mind in a form that makes finding answers in the literature difficult. So I gave an example a while ago. Will this drug work? Okay, if you focus on that in evidence-based medicine, you will need to screen through several articles, right? Or you may not find any article at all. Another example is how extensively should I investigate this patient? Okay, you must admit that you sometimes encounter these questions in practice, but I need to remind you these questions are still very general. These questions in themselves do not facilitate finding a good answer. So you need to rephrase this. You need to construct them into something that's more specific. And how do you do that? You dissect the clinical question into its component parts to facilitate finding the best evidence. I mentioned this a while ago. You go back to the anatomy of a good clinical question. You start with your patient or your population. Essentially, you're answering these questions. Which patients or populations are we interested in? Okay. Are there any subgroups that need to be considered? Even just by specifying your patient or your population, you're actually narrowing your search quite considerably. And this is actually the easiest to specify, your patient or your population. After you have specified your patient or your population, you need to specify your intervention. And these interventions can be in the form of policy, treatment, or procedure. I talk about policy because I'm in public health, but in clinical medicine, we talk about treatment or a procedure, let's say surgery, right? Treatment can be in the form of a drug, okay? So you have to be very explicit what this is. Like if there's a need for you to specify the dose or the route of administration, then by all means do it, okay? Now, after you have specified the intervention, you need to specify the comparison. So your comparison is that alternative against which you are comparing your main intervention. Okay, so your alternative can be placebo, but please be mindful that increasingly the use of placebos in randomized controlled trial is increasingly being discouraged. Um, Your comparison can be standard of care, for example. So that can be your comparison, or comparison can be another active agent. Okay, so just be mindful of that. What is the main alternative against which to compare your policy, treatment, or procedure? And then the last one, what are the important outcomes for your patient? Okay, what, let's say for example, when you talk about effectiveness of an intervention, what is effectiveness for the patient? What is effectiveness for you? Okay, does effectiveness mean the prevention of comorbidity? Does prevention mean does effectiveness mean the prevention of morbidity or death? Right? So these are questions that you need to specify. In some instances, there's an M, so it's PICOM. M would refer to your method. So this just refers to whether your search will focus on a particular study design. Okay, but we'll talk about that in more detail later. Okay, so this is the anatomy of a good clinical question. The next slides will show you the types of foreground clinical questions. Okay, so again, what are foreground questions? These are questions that your clinicians would ask. These are questions that talk about diagnosis, treatment, prognosis, harm, etiology, etc. Okay, so you contrast this again with your background questions, which talk about the epidemiology and pathophysiology of the disorder. As you mature through your practice, you will increasingly ask a lot of foreground questions more than background questions. But that's not to say that background questions are not important. Background questions are important to provide context to foreground questions. So I'm presenting here several types of foreground questions. The first would be questions on diagnosis or diagnostic tests. So when you ask a question on diagnosis, you're attempting to establish the ability of your tests to differentiate between those with and without a target condition or disease. Okay, because that's essentially the function of a diagnostic test. Your diagnostic test, especially in its most simple form, the simplest form of a diagnostic test is one in which that test will classify an individual as having the disease or not. So it's a dichotomous test, it's a binary test. Okay, so asking questions on diagnosis is akin to establishing the ability of your test to differentiating between those with and without a target condition or disease. And when you're asking a question on diagnosis, this is the structure of that question. Okay, so you start with your population. What is your diagnostic test of interest? What is your reference standard? And this reference standard is usually the gold standard. Because take note, when you ask questions on diagnosis, you want to compare the performance of this diagnostic test of interest against a reference standard. Okay, so population, diagnostic test, reference standard, and then other outcomes. Okay, I'm borrowing from the examples of obstetrics and gynecology, but this is also applicable to ophthalmology. So this is an example of a question on diagnosis. So you have here your population, the diagnostic test of interest, the reference standard, other outcomes. If there are no other outcomes of interest, it's okay. And then the study type that's usually conducted to address that question. So your population can be women with suspected tubal pregnancy. Your diagnostic test of interest can be this measurement of serum HCG. And then the reference standard would be visualization at laparoscopy with histological confirmation. Okay, so again, you're comparing a diagnostic test of interest against a reference or gold standard. This reference standard is usually one that's applied in practice more commonly, okay, or something that's been used for quite some time, or in most instances, or in some instances, it's the gold standard. Because again, you want to determine how this test of interest performs against the reference standard. So the outcome of interest here is what you call this? Tubal pregnancy. You want detection of tubal pregnancy. Okay, but you may be interested in other outcomes, such as morbidity when your test is a false negative. Commonly, studies on diagnosis are cohort studies or blind comparisons of the investigation with the gold standard. Okay, increasingly we're seeing a lot of RCTs focusing on questions on diagnosis. Okay, now so that's question on diagnosis. The next is a question on therapy. Okay, and this is the most common foreground clinical question that's asked in evidence-based medicine. So when we ask questions on therapy, we want to determine the effect of an intervention, or it can be a set of interventions on patient important outcomes. These outcomes can be in the form of symptoms, function, morbidity, mortality. In public health, we talk about cost, right? So you're familiar with this. I gave an extensive explanation a while ago, but just a review, this is the structure of your clinical question when the foreground clinical question is something about therapy. So you have your population, your intervention, your comparator, and then your outcome. Again, borrowing from obstetrics and gynecology. So you have your population. If there's a need for you to specify a subgroup, then by all means you can do it, right? Others would just lump these two rows as one. That's okay. So you have your population, the intervention of interest, the comparison, the outcome, and then the study type. So your population can be women with tubal pregnancy with a normal contralateral tube. The intervention can be this surgical procedure, and then you compare it against this surgical procedure, and then the outcome can be subsequent ectopic pregnancy. Now, we all know that the gold standard for questions on therapy are randomized controlled trials, but there are instances in which the best evidence will come from well-conducted cohort studies. I need to emphasize that when the question is about therapy, there is a need for you to specify your comparator. Okay, there's always a need for you to specify your comparator, and you need to be very specific with your outcome. Why is that? Okay, if you are open you're open for all outcomes of interest, then your search will be unmanageable. Okay, unless of course you're carrying out a systematic review de novo. Okay, then by all means, there's no need for you to specify your outcome if that's what you want. But again, that's bad practice because you're actually making your search unmanageable. So at the very least, be specific with your outcomes and you focus on what we call patient important outcomes. Okay, in some instances, although not very commonly, you may be asking questions about harm. Okay, so when you ask questions about harm, you're actually ascertaining the effects of what we call potentially harmful agents or therapies on patient important outcomes. Okay, so the structure of questions on harm kind of looks like the structure of a question on therapy. So you specify your population, your intervention, your comparator, and then your outcome. But in here, your intervention or your exposure is something that's potentially harmful. I wouldn't even call it an intervention. It's usually just an exposure. Okay. We don't see this a lot actually in evidence-based medicine, questions on harm. But just to say that questions on harm are usually addressed by observational studies. Notable of this would be your case control or cohort studies because it's unethical for you to randomly assign your participants to interventions that are harmful. Okay, so usually just have observational studies for questions on harm. Prognosis, on the other hand, talks about estimating or determining a patient's future course. Okay, in here, the clinical question is PAO, patient, exposure, and outcome. So you start with your patient or your population. What is the exposure of interest? Okay, you may have a comparator, okay, and then you may or may not have a comparator of interest, and then you specify your outcome. Again, in EBM, we don't actually see this a lot, prognosis. But in case you encounter this in your practice, the best designs for prognosis would be your prospective cohort studies. The best designs for harm would be your case control studies. Okay, so this is an example of a question on prognosis. Let's say that there's a PAO, population exposure outcome and study type. So the population can be specified as women with pregnancies of unknown location. Exposure is what they call this one, expectant management or intramuscular methotrexate. The outcome can be subsequent ectopic pregnancy, and then you can focus on RCTs and or cohort studies. Okay, now additional component, I did mention a while ago, right? That, when you talk about questions on interventions, you have your population, intervention, comparator, and outcome. Now, in some instances, you need to specify the type of question. Okay, so you need to determine whether the question is a question on diagnosis, therapy, harm or etiology, or prognosis. Why? Because the type of question will lead you to the best design. Okay, so please take note of this. If it's a question of diagnosis, this is usually the best design. It's a prospective blind comparison to a gold standard or a cross-sectional study. If it's a question on therapy, it's usually your RCT. In some instances, a well-constructed cohort study. If it's a question of harm or etiology, it's usually a cohort study, a case control study, or a case series. It's the same when the question is about prognosis. So this is very important. Be mindful of the type of question you're asking, because the type of question will often lead you to the best study design. Okay, so since we're at it, this is the structure of studies on diagnosis. Okay, so you start with patients suspected of having a target condition. Okay, so let's say it can be a patient with glaucoma, for example. Okay, so patients suspected of having a target condition. And then you apply to that particular set of patient your diagnostic test. Okay, and then you apply again to that same group of patient your gold standard. And then in that same set of patients, you determine whether the target condition is present or not. Okay, a very important feature of this is that you're applying the test, the test of interest and the reference or gold standard on the same set of patients. Okay, is that clear? Okay, you're applying what you call this, you're applying the diagnostic test of interest and the gold standard on the same set of patients. So that's usually the best design for that. Okay, so your investigators evaluate the diagnostic test by comparing its classification of patients with that of the reference or gold standard. And you're applying both tests to the same set of patients. Okay, now this is the structure of your randomized controlled trials. You have here a group of eligible patients, and then you randomly assign your patients into either treatment or control groups. At the end of the follow-up period, you ascertain for the occurrence of the outcome of interest. So randomization, what does randomization mean? Randomization means that the allocation or assignment of participants to either treatment or control is based on a random process. In short, what you call this, you may flip a coin, or pwede naman magpalabunatan, for example, although there are more sophisticated methods to do that. In short, you as the investigator does not have a say on who goes to treatment and on who goes to control. So I repeat, randomization occurs when the allocation or assignment of participants to either treatment or control is based on a random process. So examples of random processes are tables of random number. You can have a flip of a coin. You can have shuffled pieces of paper, right? Although increasingly in clinical trials, especially for large scale clinical trials, we have what we call your computer generated randomization. The central feature of that is the investigator does not have an influence on who goes to the treatment group and who goes to the control group. That's randomization. Please take note that randomization is not the same as random sampling. Okay, random sampling is when we obtain from the population a subset, right? And that selection is based on a random process. Okay, so that's random sampling. Random sampling and randomization are different concepts. Okay, so that's the structure of your randomized controlled trial. This is a structure of your observational or cohort studies. Observational cohort studies. So you have here your eligible patients, and then you classify them according to the presence or absence of exposure. If you look at it, it kind of looks like the structure of your RCT, right? The only difference is that you don't get to to assign participants to treatment or controlled groups based on a random process. You just try to ascertain whether at baseline that participant is exposed or not. Okay? So you just ascertain. So tatanungin mo lang sila. Ascertain at baseline whether the participant is exposed or not. And then you follow the groups and then ascertain for the presence or absence of the outcome at the end of the follow-up period. Okay? In here, you rely on a random process to determine the allocation of your participants into the groups. In this design, okay, you just determine at baseline whether the patient is exposed or not. That's why it's observational. Okay, you ascertain, you merely observe at baseline whether the participant is exposed or not. So what they call this, a random process does not occur here. Okay, so that's your observational cohort study. So it can be a prospective cohort study or a retrospective cohort study, depending on the timing of observation. Okay, this is a structure of a study of prognosis. Okay, so you start with patients at risk of experiencing a target event. So this event is something that will happen in the future, and you focus on patients who are at risk of developing this event at some time in the future. Okay, and then you ascertain for the presence or absence of a prognostic factor. So let's say in your discipline, patients here can be, let's say, patients at risk of developing age-related macular degeneration, for example. And then the prognostic factor of interest can be some biological measurement or some social demographic characteristic. Like for simplicity, let's say we're talking about sex, whether sex has something to do with the development of age-related macular degeneration. Okay, so it kind of looks like the structure of your observational cohort study. And then you follow this group of patients over time. And then at the end of the follow-up period, you ascertain for the presence or absence of the outcome of interest. Okay, so that's, we've covered a lot just for the first two steps. So I'm sorry if, it's taking longer than usual. So we're done with the first two. That's assessing the patient and asking the question. So let's try to put all of those together by using this scenario. It's again borrowed in internal medicine. So you have here a 65-year-old male patient was seen in the outpatient department for perioral numbness and tingling and frequent muscle cramps. Okay, the patient has been diagnosed with end-stage renal disease since 2 years ago. Blood workup revealed elevated serum phosphate levels. So the physician in charge then decided to start the patient on phosphate binders, but is unsure if he will prescribe sevelamer, which is a non-calcium-based phosphate binder, or calcium carbonate. So given this clinical scenario, as I've mentioned, you need to ask or assess the patient and ask a question. And your question should be phrased in such a way that you won't have much difficulty finding the answer. Okay, so using this case vignette, okay, the first step, or actually it's the second step already, you need to specify the components. So you have your PICOM or PICOS. Okay, my specifications are as follows. My population, adult, and someone with end-stage renal disease. My intervention is sevelamer. My comparison is calcium carbonate. My outcome is hyperphosphatemia. And then I will focus on a randomized controlled trial. Okay, so that's an example of asking the question or specifying the question in such a way that facilitates finding the answer. Okay, so this should always be the first or the second thing that you need to do once you have identified a clinical issue that is subjected to evidence-based medicine. You need to convert or phrase that clinical issue into a question that's amenable to searching. And one way for you to do that is to specify its components. So population, intervention, comparison, outcome, and if you want, the study type or the method. Okay? Be very specific because these specifications will later on be used in the search for literature. Okay, so once you have specified the components of your question, it now becomes easier for you to conceptualize or to phrase that summary question. So let's say in adult patients with ESRD, is sevelamer more effective than calcium carbonate in the treatment of hyperphosphatemia in RCTs? Okay, I know in your disciplines, you can easily, please pardon me if I'm focusing on an example from internal medicine. I just find it quite difficult looking for examples in ophthalmology. My knowledge on ophthalmology is very rusty already. Okay, but you can easily transport this or apply this in your own discipline. The main takeaway here is that from the identified clinical question that you obtain from your physician-patient encounter or interaction, you need to convert that into its specific components and then specify what those components are. Okay, so we'll go back to this example in the next step. The third step is acquiring the evidence. Okay, so why did I emphasize on phrasing the right question? Because constructing a well-built clinical question can lead directly to a well-built search strategy. Actually, if your question is properly specified, it's specific enough, for example, it's half the work done, okay? Because it's now easier for you to convert that well-built clinical question into a well-built search strategy, okay? Now, however, there are instances when it is not necessary to use all components or information from your clinical question into your search strategy. But this is very rare. For most instances, at least in EBM, we use all components. But of course, there will be very, very few instances in which it's not necessary to use all components of that clinical question in your search, okay? Now, searching involves familiarity with what we call the controlled vocabulary of your bibliographic databases. Okay, examples of your bibliographic databases would include your Medline or PubMed, right? ProQuest, for example. These are examples of bibliographic databases. So it really depends on preference. I know a lot of physicians are comfortable or familiar with PubMed. So if you're going to use that as your primary bibliographic database, then you have to be familiar with it's controlled vocabulary. Okay, so how is searching done in PubMed, for example? Okay, so these are sources of evidence. You can go through this. I think the links are still active, right? Of course, our favorite is PubMed. The Cochrane library is a good resource for systematic reviews and meta-analysis. Actually, I would recommend you to, let's say if you're given a clinical question, I would recommend that you focus on searching for systematic reviews and meta-analysis first. But usually the search will not give you anything. That's why babalik at babalik pa din sa PubMed. But it's a good start. You search for systematic reviews and meta-analysis in your Cochrane library or the Center for Reviews and Dissemination. You can also find systematic reviews and meta-analysis from the CRD. Okay. Now, Once you have identified the components of your clinical question, you now list all possible related terms. So we're now talking about developing your search strategy. Okay? So how exactly do you do that? You list all possible related terms, and your related terms will include your synonyms, your spelling variations, brand names for drugs, right? So all of this are included as related terms. If you're unsure what the related terms are, you can check what we call the MESH descriptors, the medical subject heading in Medline or PubMed. Now, when you're combining your search terms, you use what we call Boolean operators. So the most commonly used Boolean operators are and or. Okay? So what's the difference between the two? Pag ginamit mo yung and, okay, ang result niyan is it will include articles that contain both the search terms. So let's say if it's puppy and kitten, it will only give you articles that mention both terms. Okay, so yung intersection lang yung ibibigay sa'yo. So puppy and kitten, a particular article must contain, both terms in order for it to be reflected in your search. So your and operator here actually narrows the focus of your search. Okay? Ang or naman will include records that contain either of the search term or both. So in our example, you have here puppy or kittens. It will return articles that include the word puppy only or kitten only or both. So it has the effect of expanding your search. Okay, so when do you use or? When do you use and? So we'll see some examples later. Okay, so let's go back to our example on Sevelamer. So these are the components, right? And these are the concepts or the specification. Now, the third column will show you what my related terms are. So my related terms will include my synonyms, my spelling variations, and brand names for drugs. Okay, so let's say related terms will include adult. Why did I use an asterisk here? Putting an asterisk here will allow me to include all words or all let's say all words that will include the root word adult. So let's say kapag may S, it will include it. Adulting, i-include din niya. Okay, so that's one way for you to make your search a bit more efficient. So the plural form is already included here. Okay, so included here end stage renal disease. Even the hyphen variation, I included that. Okay, even spelling variation, it's renal, kidney, even what they call this, the acronym, I include all of that. Okay, so that's it. When you're conducting a systematic review, it actually takes several weeks just thinking about the related terms. Okay, for Sevelamer, I include the brand names, for example. The specific formulations, I also include that. Okay, here, this is the spelling variation that I've been talking about. So there's the English, there's the US version, and there's the UK version. So you include that as well. Okay, again, what are related terms? These are synonyms, spelling variations, and brand names for your drugs. Okay, so I limit now my study type to randomized controlled trial, and there's an efficient way for you to do it. Okay, so the next slides will show you how to effectively search for Medline. You may not be aware of it, but Medline or PubMed has changed its interface lately. Okay, so ganito na itsura niya. Okay, so the first step is of course to open PubMed. It's still the same link. However, please avoid the temptation of typing directly into the search bar. Okay, so please avoid that. Okay, once you open PubMed, you click on Advanced. You click on Advanced under the search bar. So you have this link here. So once you click on Advanced, it will actually bring you to the Advanced Search Builder. Okay, so the Advanced Search Builder looks like this. Okay. The next step now is that in the advanced search builder page, you enter your search term in the query box. So this is your query box. You enter your search terms. Your search terms should be enclosed in double quotes. Okay. Now, related terms should be combined with or. So if we go back to this slide, so these are related terms, right? So when you combine all of these related terms for the population, these terms should be combined using or. Okay. So adult asterisk or, this one, or this one, or this one. So you do that for related terms of the same component. I repeat, okay, I repeat. You combine related terms of the same component using or, okay? You combine related terms of different components using and. Okay, so let's say this is one search, okay? You combine this entire search with this using and you do the combination up until the end. Okay, so let's go back to our example. Okay, so in the advanced search builder page, you enter your search terms in the query box. Your related terms should be combined with or, okay? It's not shown here because we only have one related term for adult, right? And then you click add history. So you just don't click on search first. You see here like an arrow, okay? You click on that, it will give you this option add to history. Don't click search, just click add to history. Okay, so once you click on add to history, it will actually, just shows you like how many, shows you the number of results, for example. Okay, so adult, it's actually a matter of choice. You can actually combine one and two. Let's say wedding adult or end-stage renal disease, or you can do it that way. But I'm more used to separating adult from the disease. Okay, but you can do it the other way around. Okay, so you do that. So you see how I specified my search for search number 2, right? End-stage renal disease, enclosed in double quotes, or the next related term, or the next related term. And I do that for, so for 1 and 2, that's my P. For 3, that's my C. So PI. Sorry, for 1 and 2, that's my P. For 3, it's my I, my intervention. Number 4 is my comparator. Number 5 is my outcome. Okay? So you repeat the previous steps for the other components of the search. Okay, and in here, the yield of the search is shown in your history. And then the last one, you combine distinct or disparate search strategies with N, right? So I don't need to retype all of the search terms. I can just refer to it using the search numbers. It now becomes 1 and number 2 and number 3 and number 4 and number 5. Okay, so you're now combining search terms from different components. You're now narrowing your search. Okay, so in search number 2, for example, you are widening your search. Okay, you're widening your search because that's exactly what you want to do. Okay, but in search number 6, you're now narrowing your search. Essentially, you're just focusing on articles that contain all of these concepts. Okay, 14, that's manageable, right? Okay, so you can click on 14, you click on results to access the results page, and it will show you a list of articles. Now, you can actually filter by article type by clicking on randomized controlled trial. Okay, so I already did that, and from the 14, I have 3. Okay, so you have 3, so you just go through them. If you were to ask me, I'd look through all of them, okay, because there might be instances in which, you know, the other article, for example, has been published several years ago, and it's no longer relevant to my issue. And then you just review the results of research. So that's one way for you to effectively search Medline. Okay, the most important learning here is that please avoid the temptation of typing directly into the search bar of the main page. You always use the advanced function. Okay, So now that we're done with acquiring the evidence, the last two steps talk about appraising or applying the evidence. And in here, there are three basic questions that need to be answered for every type of study. Okay, so the first question, are the results valid? Okay, valid ba yung results ko? The second, what are the results? And then the third, will the results help in caring for my patients? Okay, so let's go through the first question first. Are the results valid? So here, I'd like to introduce the concept of validity. And validity relates to the truthfulness of evidence, how close your results are to the truth. Okay, so you say that the study is valid if the findings are very much close to the truth. But the problem is we don't know the truth in the first place. That's why we're conducting a study, right? That's why we're conducting a study on a limited number of patients because there's no way for us to study the entire population. And in some instances, we don't even know what the truth is. Okay? So validity is actually very difficult to assess empirically. That's why we rely on good study design, good implementation of study procedures, right? To give us some indication of the validity of your evidence. Now, please take note that the validity criteria, and you will see a lot of this validity criteria as we go through critical appraisal. Your validity criteria should be applied before an extensive analysis of your study data. Okay? Kasi if your study is not valid, then the data may not be useful. If your study is invalid in the first place, no matter how nice the study findings are, those study findings are likely to be false. Okay? That's why, what they call this, it's something that you develop as you go through the practice, actually. When I was starting out as an epidemiologist, and when I was a medical student, and a consultant or a resident or a fellow assigns an article for appraisal, or just assigns an article out of a sudden, um, the first thing that I would usually go to would be the results. Okay, because the results are something that I understand, right? But that's actually bad practice because before you even delve into the results, you need to go through the methodology. You have to assess whether methods were carried out, whether methods were proposed correctly and whether methods were carried out correctly. Because if the methods are incorrect, then most probably the findings will also be incorrect. So this is my take home point here. The validity criteria should be applied before you even extensively analyze your study data. Because if your study data because if your study is not valid, then your data may not be useful at all. Okay, I know we don't like reading the methodology, especially for epi papers, for epidemiologic papers, but we have to go to get into the habit of doing that because evidence that supports validity is found primarily in your study methodology. So you go through that, okay? You examine the study methodology. And in some instances, answers to questions of validity may not always be clearly stated in the article. So you may have to make some grand assumptions, but again, be very careful when you make such assumptions. Okay, so are the results valid? So that's the first question. This actually, are the results valid, actually refer to a set of questions. So we'll discuss what this set of questions is in maybe by Sunday when we talk about specific critical appraisal techniques. Okay, the next set of questions, what are the results? Okay, so this is the math part of it. So what are the results entails the computation of the following measures if your outcome variable is dichotomous. Okay, so what's a dichotomous variable? It's a variable that takes on two possible values. So let's say mortality is an outcome variable that's dichotomous because you can either be dead or alive. There's no in between. Okay, the presence or absence of a disease, for example, that's a dichotomous variable. So if your outcome of interest takes on two possible values only, or is dichotomous, or is binary, Then you can compute for your relative risk, your absolute risk reduction, your relative risk reduction, and the number needed to treat. Okay, I know we've been talking a lot of theory lately, but I just want to introduce the concept as early as now, so that when we meet again on Sunday, you won't be surprised with the computations. Okay, so you're all familiar with the 2 by 2 table. So this brings back memories of clinical epidemiology in medical school, right? And epidemiologists actually like this 2 by 2 table. So you have here on the rows your treatment. So you can either be in the experimental group or your control group. And then the columns will classify whether you have the disease of interest or not. So let's say persons in the A cell are those in the experimental group and who develop the outcome of interest. Okay, patients in the or participants in the B cell are those who received the experimental treatment and who did not develop the outcome of interest at the end of the follow-up period. So that's A, B, C, and D. Okay, so this is your experimental, your control, with disease, without disease. In some instances, your experimental is labeled as exposed. Your control is labeled as unexposed. So it's just a matter of terminology. Okay, so we have what we call your experimental event rate, so your EER. Okay, it's actually the proportion of those who receive the treatment and who develop the outcome of interest. So it answers the question, among those who received the experimental intervention, what is the proportion who develop the outcome of interest? Okay, so A plus B received the experimental intervention. And out of A plus B, A developed the outcome of interest. In a randomized controlled trial, we also call this the incidence in the expose or the incidence in the experimental group. Okay, experimental event rate. So if there's an experimental event rate, there's also the control event rate. Okay, so C plus D, those are individuals, that's the number of individuals who received the control intervention. And out of C plus D individuals who received the control intervention, C developed the outcome of interest. So this is the incidence in the control group or your control event rate. Okay, so you have your experimental event rate, EER, incidence in the experimental group, and then you have your incidence in the control group or the control event rate. Okay, that's your CER. And if you take the ratio of that, EER divided by your CER, you have your relative risk. So that's the all too familiar relative risk. In epidemiology, we want to be precise, we call this your risk ratio. Okay, so your relative risk will tell you how many times more likely it is that an event will occur in the treatment group relative to the control group. So we'll talk about interpretations, specific interpretations next Sunday. So this is the hard and fast interpretation. If the relative risk is equal to 1, then there's no difference in the risk of outcome between the groups. So you say that your experimental intervention does not have an effect, right, on the outcome of interest. Because it does not matter whether you're in the experimental group or the control group. The rates, what they call this, of disease or the incidence of disease will be the same anyway. So a relative risk of 1, there's no difference in the risk of the outcome between the group. If it's a relative risk of less than 1, then you say the treatment is beneficial. Why is that? Treatment is beneficial because you have lower incidence of the disease in your numerator compared to your denominator. So you say the treatment decreases the risk of the outcome. Okay? In a randomized controlled trial, we want a relative risk that's less than 1. If it's a relative risk that's greater than 1, okay, if you go back to the formula, it just means that there's higher incidence of the disease in the in the experimental group compared to the control group. So your treatment is harmful because it increases the risk of the outcome. Okay, so that's your relative risk. The next is your absolute risk reduction. Okay, so we're done with we're done with the relative risk. So that's the RR. Kung may RR, may ARR. Okay, your absolute risk reduction. It's just the difference between your EER and your CER. Okay, you may have encountered or you may have encountered this as risk difference because it's just the difference between risks. It's the same computation for your EER and CER. Okay, the beauty with your ARR is that it tells you the absolute difference in the rates of disease or in the risk of disease between the two groups. Okay, the interpretation of your ARR is kind of the same as that for your RR, but the referent now, the null value now is 0. Okay, in the previous slide, the null value is 1, right? That's the value of no difference. That's the value of no effect. Okay, in your ARR, the value of no effect is 0. Okay, because you're talking about differences. Okay, so 0. If it's an ARR of 0, the experimental therapy has no effect. If it's an ARR of less than 1, treatment is beneficial. If it's an ARR of greater than 1, treatment is harmful. Okay, there's what we call a relative risk reduction. We also call this our treatment effect or TE. Okay, it's just your EER minus your CER divided by your CER. So the numerator here is your ARR, right? Okay, so that's your absolute risk reduction. And then if you divide your absolute risk reduction by your control event rate, that's your relative risk reduction. You can also express your relative risk reduction by 1 minus RR. And this is actually the easiest way to compute for your RRR or triple R. Okay. Your relative risk reduction will give an indication of the reduction in the rate of the outcome in the treatment group relative to that in the control group. So let's say if your RRR is 95%, that's a good RRR. It just means that there's a 95% reduction in the outcome in the treatment group compared to the control group. So that's good indication of treatment effect. Okay, so that's your RRR. Don't worry, we'll be focusing on interpretation next Sunday. Okay, and then the last one is your number needed to treat. It's just 1 divided by your ARR. How do we interpret this? The number needed to treat is the number of patients we need to treat with experimental intervention in order to prevent one bad outcome. So it's a measure of clinical significance. So we want an MNT that's small. We want to treat a small number of persons to prevent one bad outcome. So that's the number needed to treat. Okay, so it's a measure of clinical significance. Although, again, as a disclaimer, increasingly your NNT is being criticized, right, for what they call this, for interpretability concerns, but we'll not be focusing on that in this session. Okay, so those are the quantities that we will be computing next Sunday. So it's actually quite interesting. Now, in addition to computing for the RRs, the RR, the ARR, the RRR, and the NNT, daming R, okay? We also judge on whether the findings are statistically significant or not, okay? So statistical significance is powerfully influenced by the number of observations. So the larger your sample size, the more likely it is, although it's not always the case, but the more likely it is that your findings will be statistically significant. So you may have heard of statistically significant as, a p-value that's less than 0.05, for example, or if you talk to your statistician, sometimes they judge your statistical significance by your confidence intervals. And that is usually a function, but not always, a function of your sample size, okay? As long as the sample size is large enough, right? The problem is that small changes in important outcomes may be statistically significant. That's the drawback. Okay, let's say even if the difference in the outcome between your groups is very small, if your sample size is very large, that very small difference may still be statistically significant. Please take note that there's a difference between statistical significance and clinical significance, because clinical significance has little to do with statistics and is a matter of judgment. Okay, it depends, among others, on the magnitude of the effect being studied. Okay, it answers the question, is the difference between the groups large enough to be worth achieving? So to differentiate between the two, statistical significance versus clinical significance. Let's say I have a large study that found that a new antihypertensive drug lowered systolic blood pressure by an average of 1 millimeter mercury more than conventional treatment. However, the p-value is small, it's less than 0.05. Okay? My question now is the finding statistically significant? Okay? If there were a poll, I would ask you to answer this, right? Uh, but since we don't have that, okay, I'll say that the finding is statistically significant because the p-value is small, right? Ito yung gusto nyong p-value in your researches, right? A p-value that's less than your level of significance, a p-value that's less than 0.05. So this finding, that 1 millimeter mercury difference in systolic blood pressure between the two groups is statistically significant. Now, it's a different question when I ask you this, is that finding clinically significant? Okay, I've presented this example to nephrologists, to endocrinologists, and I've been getting the same answer all over. Okay, while the finding is statistically significant, a 1 millimeter mercury is not clinically significant. So there's always a need for you to balance, between the two, statistical significance versus clinical significance. And you would see a lot of philosophical, discussions about this. Ako, as an epidemiologist, I usually look into the clinical significance of my findings. Even if I'm heavily quantitative, I'm not a fan of significance testing, but that's just me. Okay, I usually look into a lot of things to interpret findings from studies or findings from my own studies. Okay, and then the last question is still talking about appraising and applying the evidence, is that will the results help in caring for my patient? So once you have determined that your method is valid, that the study methodology is valid, you must now examine your results and whether such findings are applicable to your patients. So you ask questions such as, did the study include patients similar to your patient? So you now talk about transportability of your findings. Will I be able to transport my findings to my patient of interest? Okay, so these are the signaling questions. Did the study include patients similar to your patient? Did the study cover the aspect of the problem that is most important to your patient? And are the likely treatment benefits worth the potential harm and cost? Okay, so actually applying the evidence for me from a practical standpoint is the most difficult step to implement, right? Because it's in here where you're now integrating several streams, right, of influences, right? You're not just what you call this, considering clinical evidence or research evidence. You're now, putting into the decision-making process your expertise, the patient's values and preferences, even questions of economics, for example, or even the preferences of the relatives, for example. So this is where the real work of medicine comes in. Okay, so again, as a summary, what are the steps in EBM? You always start with the patient, okay? You assess your patient because clinical questions in evidence-based medicine always arise from patient encounters, physician-patient encounters. There are issues arising from these encounters, and these issues you need to transform into a clinical question, which brings me to step 2. You ask the question. So once you have rephrased that particular issue into a question that's amenable to a search or amenable to finding an answer, The next step is to acquire evidence. Okay, and the take home message there is that avoid the temptation of directly inputting your search in the search bar. You use the advanced function. Okay, the next now is to appraise. And our primary consideration here is looking at the validity of your findings before even going into the results. Because if the findings are, if the method is invalid, then the higher the probability or the likelihood that your findings will also be useless. And then for me, the most important, you apply the evidence. So this is where your expertise comes in. You integrate it with evidence and then the patient's values and preferences. Okay, so these are my references. Thank you so much for listening. At this point, it's now 11:02. I think I'm supposed to end at 11. I think I'm on track, right? I'm supposed to end at 11. So we have some time for Q&A.
Yeah, thank you very much, Amiel. That was a comprehensive lecture on the basics of evidence-based medicine. Before we move on to the question and answer portion, let me remind everyone to fill out the feedback forms posted in YouTube, Facebook, and the Zoom chat boxes. This will serve as your attendance for this session. For those with questions, you may still post them in the chat boxes, or those using the Zoom platform, you may also raise your hand and wait to be acknowledged. So for our first question, can we have it posted?
Okay. Sige po. From Dr. Ron, is a grade framework used to assess individual studies, or can it also be used to summarize recommendations from several studies? Okay. The grade framework is not used to assess individual studies. It's used to assess a group of studies that yield, how do I erase? Okay, ginagamit kasi natin, we use the grade framework when we're trying to determine the quality of evidence from a systematic review and meta-analysis. So the way we do it is that, let's say at the end of your meta-analysis, you have what we call your pooled relative risk, right? Let's say RR that you pull from 5 randomized controlled trial. Let's say the outcome of interest is death. So for the outcome death, you were able to find 5 studies that had death as the outcome. And then you pulled the studies using meta-analysis, and then you arrive at what we call a pooled relative risk. So we use the grade framework to assess the level of the quality of evidence for the pooled relative risk. Sabihin natin the pooled relative risk or the combined relative risk is 3. Okay, so to answer the first question, no, it's not used to assess individual studies. It's used to assess usually a group of studies, what we call this, that's the basis for pooling results in a systematic review and meta-analysis. And then, yung finding mo from your grade, and this is to answer the second question, can it also be used to summarize recommendations from several studies? It's used to assess the quality of findings from several studies that you pool using meta-analysis. And then that pooled, what we call this finding, for example, that pooled relative risk is then something that you use to arrive at recommendation. So that's the process, okay? So you perform a systematic review and meta-analysis first. You subject the findings from your SR, systematic review and meta-analysis, into the grade framework, and then findings from applying the grade framework will help you in developing your recommendations. Kaya when we create clinical practice guidelines, yung nilalagay natin na level or quality of evidence, yung high, medium, low, very low, that came from the grade framework. Okay, so yun yung proseso po niya. So I hope I was able to answer that, Dr. Pipo.
Okay, for the next question, can you give a quick review on the difference between the types of studies like cohort, case control, and RCT? I'm sure you will be discussing all of this much in the later sessions, right?
Oh, yeah. Okay, mananawa tayo dito between the cohort study, the case control, and the RCT. But let me just answer this very quickly. I think we have enough time. Your RCT is an experiment. All of these study designs are what we call analytic study designs. They're analytic in the sense that you're attempting to answer questions on cause and effect. You want to determine whether your exposure has any effect or relationship on your outcome of interest. You contrast this with a descriptive study, which we will discuss in the succeeding session. So all of these are analytic studies. Your cohort and case control studies are observational analytic studies. Why is that? They are observational analytic because, let's say, for example, in a cohort study, you just observe for the presence or absence of exposure. Okay, so you don't allocate, you don't randomly assign, or you don't, let's say, you don't tell to the participant, okay, for the sake of this study, please smoke for 5 years. You don't do that. Okay, so you just ascertain whether an individual has the exposure of interest or not. In a case control study, you just observe or ascertain whether an individual has the disease of interest, in which case that individual is a case, or if that individual does not have the disease of interest, in which case that individual is controlled. So for cohort and case control, they're observational in the sense that you're merely observing for the presence or absence of a particular attribute. In an RCT, it's an analytic study pa din. However, it's experimental. It's experimental in the sense that you can now deliberately apply or withhold an exposure of interest. And this can be in the form of treatment. And that deliberate application or withholding is something that's dictated by your randomization. You can actually, deliberately allocate your participants into treatment or control groups, right? Using randomization. So that's the main difference between the two. In cohort and case control, you don't have much control over the patient's exposure outcome status. You just observe them as they are. In RCT, you have some degree of control in the allocation of your participants into treatment groups. So I hope I was able to give you a quick answer to this, but we will be discussing this during the bootcamp on research methods. We have a whole session on study designs.
Okay, excellent. If several RCTs were found after the systematic literature search, how do we decide which RCT to use?
Okay, this is quite tricky, and this will, you'll mostly encounter this. In practice, what I usually do is I try to limit it by the year of publication. You may want to focus on articles that's published more recently, for example, or you may want to look into whether that particular RCT was published in a reputable journal. In your discipline, you may have a preference for one journal over the other, right? So there are a lot of decisions that come into play. But usually the best decision is that if you have several RCTs addressing the same question, it just means that several RCTs have already been done, and the best course of action is to synthesize findings from these RCTs, and that would mean conducting a systematic review. So that can actually be, a subject of your of your research project for residency. So yun yun.
Related to that question, if a systematic review is available to answer the clinical question, can we use that instead?
Oh yeah, definitely. But then you will need to apply a different set of appraisal criteria for a systematic review. Okay, so we will be discussing that on the fourth session for EBM. Okay, critical appraisal of a systematic review.
There's another question. What would be our alternative if we do not have a published RCT that answers the clinical question?
Okay, so if you don't have a published RCT that answers your clinical question, you may want to go back to the evidence pyramid. So you may want to, let's say, instead of delimiting your search to RCTs, you may want to include cohort studies, for example. So cohort studies, pag wala pa din cohort, pwedeng case control, and so on.
And of course, Amiel, you mentioned that sometimes an RCT may not be possible for a particular question because randomizing a treatment or an exposure can be bad for the patient population. So
Exactly,
sometimes the
exactly.
best evidence might be from a cohort study.
Yeah, that's true.
Yeah,
That's true. And even a case control study. So it's
correct.
not,
Yeah.
yeah. So it's not a matter of whether there's an RCT or not. What's the best design that can address your question?
Okay, we have some more questions. How do we interpret the results of RCTs where the outcomes of interest are quantitative in nature?
Okay. So the ones that I presented a while ago, the outcomes can take on two values, either it's present or not. In ophthalmology, for example, you have outcomes that are continuous. Let's say intraocular pressure is measured in millimeters mercury ba?
Yes,
Yeah, so ang IOP naman ninyo, hindi yan present or absent, right? So it's
yes,
measured on a continuous scale. So ang tanong ngayon, pwede ba natin gamitin yung 2 by 2 table na pinakita ko? Of course not. Okay, so you don't manually compute for RR. But it's not covered in this session, but hopefully I'll be able to find an article in which the RR is estimated using regression modeling. Okay, but but it's still possible for you to obtain relative risk, okay, if your outcome is continuous in nature, but the relative risk is not something that you can manually compute. It's usually outputted, for example, by your statistical software because we can apply certain regression procedures to estimate the relative risk. So wag niyong pilitin, kasi I've seen this a lot, wag niyong pilitin mag-compute ng relative risk when your outcome, relative risk using the 2 by 2 table, when your outcome of interest is quantitative. That will be very difficult.
excellent. So, do you have any more questions? So, mukhang walang natulog. Marami tayong questions ngayon, Amiel. You mentioned earlier pala that with regards to the hierarchy of some journals, because we see that there's some journals which in publication have a higher status than others. Please explain to our residents why there is such a like publishing in Lancet or Nature
Oh
or
yeah, what do you call this? Uh, yeah, so when we talk about the reputation of a particular journal, it's actually a complex issue. But the quick and fast rule for that is usually look at the impact factor, right? So the higher the impact factor, the more reputable that journal, and then you make the assumption that the more reputable the journal is, the more rigorous the peer review process is. Right? So siguro in your discipline, you would know what the reputable journals are. In my discipline, epidemiology, the reputable journals are the American Journal of Epidemiology, the International Journal of Epidemiology. So you just look into impact factor. But I think what's most important, and I will include this siguro in when I'll be sharing my slides with you, is that please be mindful of what we call predatory journals. Okay, so ito yung mga journals na kahina-hinala. Okay, so there's a list called Bill's List. Okay, so dun sa list na ito, it's accessible online. You will see the list of what we call predatory journals. So if that article is coming from a predatory journal, please don't include it in your EBM because the more likely it is that that particular article did not undergo peer review or it may actually be fraudulent. Okay, so please be mindful of that. I think that's a good question actually, Doc Rainer. And one thing that I really want to emphasize is be mindful of predatory journals. Not all journals are created equal. Okay, so look at the impact factor. If you're more inclined to do that, or just rely on the more reputable journals in your field. But I think the more important advice: be mindful of predatory journals. Ito yung mga I've received a lot of requests from predatory journal, parang submit your article now and then have it and then tomorrow available na raw siya for publication. Parang what? Like in 12 hours daw mapapublish na nila yung article mo from submission, samantalang ordinarily it takes around 3 or 4 months from submission to publication. So these are really dubious journals, so please be mindful of that.
excellent. So I think that's our last question. At this point, I'd like to remind everyone to fill out the evaluation forms. Again, that will be the basis for your attendance and for your certificates. Let me remind you also that this bootcamp is comprised of 3 modules, and we will be giving certificates per module for the participants with complete attendance. We have applied CPD units for this workshop as well, so if it is granted later on, you may apply for it retrospectively. For your co-residents, colleagues, and consultants who were not able to watch this live, this broadcast may be seen on YouTube or at the PAO Facebook page. Once again, thank you very much, Dr. Amiel, and to Edsel, and thank you to everyone for joining us in the first episode of our PAO Online Research Bootcamp. I would like to personally thank the Research Bootcamp Committee members, Drs. Eleanor Iguban and Jazel Redondo, our IT team, Drs. Jet Rayel, Roel Villanueva, and Paul Gomez, and our staff member, Joshua Puti, for helping organize this event. We have 7 more exciting episodes in store for you, so don't forget to tune in again on September 13, Sunday, 9 to 11 a.m., for your second episode, which will be about critical appraisal of an article on diagnosis. Take note that all our remaining episodes will be on a Sunday, so we will have 7 Sundays left. See you all again next week. Enjoy the rest of the weekend and keep safe. Bye for now.